Hello, everybody, and thanks for a small but intimate group to come to this. This is actually one of the important talks because there are things from a patient perspective, from a pharma perspective, of what can be done to help and really what we've learned. And truly, blood, serum, sweat, sometimes they collect that. They collect what's in your mouth and your tears and skin biopsies. So all those things and what we've kind of learned from registries, and for the patients, what can be done to help in registries as a patient volunteering some of their tissue or their time, and from pharma, where can there be really good partnerships. So these are some of my disclosures. And really, I think the most important thing is to understand the value of registry data, but also the limitations, to compare it to randomized controlled trials, because trials are very, very expensive, and registries can answer different kinds of questions, and really to understand how we classify scleroderma, because we use registry data for the classification, to understand what organs to screen for, and to give knowledge on emerging treatment that has developed from registries and from randomized data. So there's advantages and disadvantages of randomized controlled trials. So randomized controlled trials, you have a chance of getting one treatment or a comparative, or the comparative might be a placebo. If there's two arms in a trial, it's a 50-50 chance. Sometimes it's 3-to-1 chance of active versus placebo. So the odds can vary. But the patient, the investigator, the study nurse, the sponsor, no one chooses who's on what. So they are randomized, which eliminates some of the bias or confounding. So if we had all the really healthy people with scleroderma in one group and some sick people in another with scleroderma, then you have an uneven distribution. So randomization, luck of the draw, evens that out. So advantages of randomized controlled trial, you can show cause and effect. The people on the active treatment got 30% better. The people on the fake got 10% worse. Cause and effect. Fake, you got worse. Active, you got better. Whereas in a registry, you don't know what else is going on, why people are prescribing something, so there's a lot of potential bias. Double blinding is the best kind of trial, where the patient, the investigator, the study nurse, the pharmacist, nobody knows who's on what. You can't do double blind like the stem cell transplant. You can't fake a stem cell transplant, so that was not blinded at all. But there might have been someone that assessed the skin score who was blinded as to what treatment they got. But it'd be pretty easy if someone had lost all their hair to say, oh, you probably got induction treatment for stem cell transplant. So you can't always blind, but double blinding, meaning patient and the other people involved in the trial don't know who's on what, is the best kind of trial. And then any trial is internally valid, but I could find in one study that, say, methotrexate to soften skin worked and improved skin softening by 15%, and placebo, it improved by 2%. And in another trial, because there's two randomized controlled trials with methotrexate, maybe you find it improves skin by 25%, but placebo improves by 10%. So you can see the answers are a little bit different, but there's a relative delta or change between active and placebo. That kind of thing is often consistent between trials, but doesn't have to be. The big disadvantage of randomized controlled trial is cost. Every trial costs millions of dollars in general to perform if it's a treatment trial. Even observational trials where we're collecting data and randomizing people of, collecting a bunch of questionnaires, and they get an intervention that's standard of care, or standard of care plus an add-on, or two different cares. Even they cost a lot of money, the logistics of it. And the other disadvantage is that it's not always ethical. I can't randomize people to stop smoking. I'd love everyone that smokes to stop smoking, but you can't randomize for that. So there's ethics sometimes within trials that you just can't blind, or you can't do it ethically. Also, the follow-up's pretty short. I'm treating patients with scleroderma for possibly the rest of their life. And so, a trial that goes 1 or 2 years or even 6 months is quite short, whereas I need to know, does this still work in 5 years, or is it that I should treat you for a while and back off treatment, or give you something less expensive or less toxic, or add something to it if you're doing worse? All those questions are usually figured out in the real world after a drug comes available. The population is usually not generalizable. So in a randomized controlled trial, we look at people that are really adherent, so they're quite compliant with treatment. They usually have to be sick enough, but not too sick, not other comorbidities that might interrupt the treatment or interrupt the safety of the trial or affect the safety. So usually treatment trials are very narrow in who's allowed in, but then in the clinic, I got to treat a bunch of people and say, I think this might be generalizable to some of my population or not. We don't know long-term safety, so it's we have fancier drugs now in scleroderma. Biological drugs are being studied, and we only know the short-term benefit, but also the short-term risk. So does benefit attenuate or dampen over time, and does risk go up, or do both stay about the same? It's really tough to know. In general, risk goes down over time. Your highest risk of a new treatment is early on, and then the rate goes down. And I'll give you a comparison. So the tocilizumab trial in scleroderma, randomized controlled trial, early active diffuse systemic sclerosis, had to have a skin score between a certain range, not way too high, not way too low. And the serious event rate was 10 times higher in this dose than what it would be in rheumatoid arthritis. And you go, holy smokes, this drug's really unsafe. But in placebo, the serious event rate was about 3 times higher than placebos in rheumatoid arthritis. So relatively speaking, it was actually a more toxic drug in scleroderma than rheumatoid, but even background had more side effects. So that's a good example where you have to study the population of interest. So there's some of the advantages and disadvantages, but cost, ethics, and the short-term duration and generalizability are the main disadvantages. Registries are observational, so it's usually anything goes. It's not usually, oh, we'll randomize clustering one site for one treatment, another site with another. It's usually just treat people and see what happens, or follow people that have scleroderma or people that are with scleroderma at risk for pulmonary hypertension, whatever. The registries can have different inclusion criteria, but you can get more people in, so you can study more people. You can find out the natural history of the disease and with the current standard of care, and you can compare it to old care. You can look at better safety. So as I say in randomized trials, because your body hasn't adapted to the new drug, or you drop out if you have a serious side effect maybe. So people that are doing well, that tolerate a drug, usually go into open label long-term extension studies. Or in the real world, if they tolerate it enough, they'll stay in. In a trial, they might have to be kicked out if their liver enzymes go up too high, or if they have a serious infection. You can look at different clinical scenarios. So I treat mild, moderate, and severe patients, but maybe in a trial only moderate are allowed, or maybe only severe are allowed in. And registries, you can look at cost effectiveness, cost benefit, so look at resources that are utilized. You can look at comparisons, so we call that comparative effectiveness. So I wonder what drug A compares to drug A plus B. And you can generate hypotheses. It's hard to prove a hypothesis, but you can generate, oh, I studied this, found this, I think we can study it in a trial. I found that as a, for instance, I'll just say something like rituximab softens the skin in a case series that I've looked at, maybe we should do a proper trial, as a for instance. So when you look in the literature, mostly what randomized controlled trials find, the results are similar in registries. So 9 out of 10 times, it's the same. But there are limitations of registries. There's different follow-up, different outcomes looked at. The time that you see people could be different. That's someone you're seeing monthly in one center to every 3 months or every 6 months in another center. And you have to kind of figure out follow-up time, patient years of observation. There's different treatments. So if we compare what we're doing in the US to, say, Europe has Bosentan for the prevention of digital ulcers. We do not have that approval in North America. So the treatment to prevent digital ulcers will be very different comparing countries, and that's an easy example. Also, different drugs come out and are reimbursed at different times in different jurisdictions. There's different cost structures, so I can order whatever I want and say it's for clinical care in Canada, whereas if an HMO or some kind of managed care in the US, you might have to justify, why is it you're doing breathing tests again on this patient who's had 2 normals the last 2 years? Why do you want to do it? So sometimes cost utilization is a real problem because you're trying to have the system pay for something that is really, in a way, research, or we're observing on a standardized protocol. We don't know if people take their drugs, so in randomized trials there's pill counts. In the real world it's whatever goes. So I prescribed it, you might not even fill the script. So as for instance, people with low bone density, osteoporosis, the amount doing their second script is about 30% if you don't hound them to do it. So a lot of people, about 85%, fill their first prescription for osteoporosis. Their second script, which their first script could have many refills, but the second time around it drops way down. So I could prescribe a therapy, and if you can't in a trial, you might get it for free. In the real world, you might say, oh, I can't afford my copay, so I don't even know if people are taking it. And comorbidities. So you could do unwell, poorly in a study, and it might be nothing to do with your scleroderma. It might be the fact that you also have severe diabetes. You'd be excluded from a trial, a randomized trial, but I can do an observational study, and whatever happens, you don't know the attribution of, do I blame it on the drug or on a different disease or whatever. So they're different. So I'm going to use a Canadian example because our Canadian Scleroderma Research Group, also known as CSRG, we started a registry multi-site many years ago now. So it's not all over Canada because no one lives up here, in honesty, but it's mostly, no one lives up there. We only live clinging to the US. We live right around the border, all over the place. But it's multi-sites in multi-provinces, and that allows you to have that heterogeneity. We're going to look at a lot of different things. They're large expert sites and some sites that have an interest but are not nearly as large. They're not known to, say, before this to have published in Scleroderma but have a real interest. So variation of site size and location. And we collect, this is kind of an old slide now, but we have now about 1,400 patients with at least one database, and we have about 1,100 now on 2 years of follow-up. So all this stuff is transferred over by a year because we keep enrolling and we keep following people. And bizarrely, we can collect as much as 1,000 data points. That's if you had everything done, a high-resolution CT scan and ticking all the boxes of what people have and all the ancillary questionnaires. So we collect a ton of stuff, which is a burden on patients sometimes. So we have kind of short form years as well, and for people, they have to be literate in English or French to enroll in this, or else their family has to read it to them to consent them and do it. So literacy is important. So who do we evaluate? We evaluate anybody with that a expert says has scleroderma. So they don't have to meet fancy criteria, old criteria, new criteria. We evaluate them yearly. So if I'm going to give a treatment protocol where the next 3 months are really important, I won't capture that in this at an annual visit. So I might have it in my chart, but it's actually not in the registry. Some registries are every 3 months for the first 2 years, like early suspected scleroderma in the European group, very early suspected scleroderma, VDOS. They collect visits really frequently because they want to see the change over time. We collect and freeze serum at every visit. So annually, we have a whole bunch of serum that's spun down and banked. So we have blood. We don't have sweat and tears in this one. And optionally, people can do skin biopsies, but it's usually early active patients, and the biopsies are usually paired. So 2 chunks of skin beside each other, and why we do that, I think, is to divide it up for labs more easily. And there's a new patients, incident cohort, but there's prevalent patients, people that have been around a long time. So at first it looked like if you entered this registry, you just don't die because they were already survivors. So the mortality was really low, and you can't compare mortality then because if you're already around 8 years with your scleroderma, maybe you're more likely to be around the next 8, whereas if you're only at year 2, you might die off before you get followed a long time. So in our outpatients only and by rheumatologists only. So we don't have pulmonologists or gastroenterologists or cardiologists entering this. And we can do comparison studies. So you can look at different sites and compare them. So we've looked at best practices and found that even though there's an interest in scleroderma in all these sites and they had to have a minimum amount enrolled, we found a total size difference that if you were a small site, you had less pulmonary arterial hypertension, which doesn't make any sense. And if you're a large site, you had more, but you had the same amount of interstitial lung disease, the same bad gut, the same digital ulcers. So what we found was that the small sites, the screening was not very good. So we had to enact that, please make sure the right heart of the echo is read. So it took a few years for their screening to be done right, so they were not detecting patients. So we found a best practice was larger sites do better because they had experts on site to read the echoes properly. That's no longer an issue, fortunately. But it wasn't that they were milder patients because they had the same rate of other problems like interstitial lung disease and heart disease and stuff. So if we look, here's one study showing a whole bunch of different databases and showing the epidemiology of scleroderma. So scleroderma around where I'm from in London, Ontario, so kind of near Detroit, which probably means pollution and stuff like that. St. Clair River, car manufacturing, silica dust, which is a risk. There's silica in the window production for the windshields and stuff of cars. So around where I am, it's 2 in 10,000, which is one of the higher but not highest reported. So the highest reported prevalence of scleroderma is actually Choctaw Indians in Oklahoma. So what happened was probably it's polygenic, probably the genes from this tribe were important, and there was only a few families from France, the settlers, that married in there, and they think that it was probably the perfect storm of 2 sets of genetics that increased the risk, and that's about 50 per 10,000 at highest. And if the guys or gals moved off the reservation, so 1 or 2 generations down, it went down to about 10 in 10,000, which is still higher, but it went down. So it was probably nature and nurture, probably something environmentally that we don't know and the wrong combination of genetics. But this just shows what registries can tell us. You can look at the variation of prevalence of a disease, and not always will you capture everyone. So there's really good prevalence studies in Sweden and Scandinavia where everyone from beginning of life till death is on a registry because they have one paying system. It's like they have one HMO kind of thing or one payer, so everything's collected. And this is something that registries have shown us. So the 15% rule, we included registries that had at least 50 patients. So if you had a case series with less than 50 people, we didn't stick those registries in. And this is where registries came from. So it shows you a lot of registries, not surprisingly, are from Europe and North America, but also Australia, Japan, different genetics there and stuff. And the 15% rule was really devised to help people learning about scleroderma, so medical students, non-experts, such as your rheumatologist that doesn't have a big scleroderma population, and basically renal crisis, so the kidney crisis in the early diffuse group is 12%, but overall is about 3%, but heart involvement overall 3%, but if you put all sorts of other heart issues like heart failure, arrhythmia, diastolic dysfunction, valvular disease, which valvular really isn't part of scleroderma, but the other ones are, or fluid around the heart, pericardial effusion, pooled, it's 15 or 16%. And you can see 10,000 patients going into this study, all these registries combined, 11,000 going into this part, 1,000 going here. So basically, the 15% rule helped people to understand how common things are. So 15% of patients have, by right heart catheterization, pulmonary arterial hypertension. And it's as low as 8% and as high as about 20%, depending on the registry. So clinically relevant interstitial lung disease is about 15%, but interstitial lung disease is about 1 in 3 diffuse and 1 in 4 limited. So it just shows how registries show stuff. 17% having restrictive lung disease, same amount, 15% having moderate restrictive lung disease, and so forth. So this is what registries can tell us. So this is our little rule of thumb that I think helps people to understand what registries can tell us, prevalences. Then we developed the new American College of Rheumatology European League Against Rheumatism criteria for scleroderma. And so we have criteria, but these criteria were tested and validated on registries. So there were about 22 sites in North America that contributed data, same in Europe. And we had a validation and a testing cohort. So we wouldn't have gotten these criteria without a whole bunch of sites pulling together, and they had to do new patients for half of the amount that they enrolled, 20 patients each, and prevalent patients, just your next 10 people coming through to get, or your next 20 coming through, to help kind of understand for new patients as well as long-standing what the criteria were. And because scleroderma is so complex, you'll never get randomized controlled trials of every single feature. So everybody pretty much with scleroderma has GI involvement in Raynaud's. And although we have many Raynaud's trials, we have very few randomized controlled trials of gut involvement in scleroderma. So swallowing tube issues like dysphagia or acid reflux issues. So with the complexity, you just won't get trials in every single organ. And we screen, so registries tell us we should screen for, and World Health Organization as well, for pulmonary hypertension. So an echo doesn't make a diagnosis, it's a screening test, and a right heart catheterization under standard criteria, standard protocol will make the diagnosis. And pulmonary arterial hypertension is a lethal complication of scleroderma, and it's common. It's 15% of our patients, 1 in 6. So we should screen if you can treat and intervene early in a common but lethal complication. That treatment will prolong life and improve quality of life. So here's 2 registries. So a REVEAL registry in the US was a little bit different, but did have scleroderma patients that they screened for pulmonary hypertension. But this is a French registry of scleroderma and an Australian one. And what they found was that if they screened their patients with scleroderma, they found that pulmonary hypertension was just what we thought, 15% of patients. But if you screen them, they were better off. They presented less sick, less short of breath, better walk distance in 6 minutes, and less bad right heart cath findings. So screening gave early detection, and it's registries that prove that, and now many more registries have proved that. There's also here, headed by Dr. Virginia Steen, the Pharos registry, and that is not just scleroderma patients. It is scleroderma patients that meet inclusion criteria. So it's not all comers. These are patients that have to have higher risk of pulmonary hypertension because they wanted to look with a low diffusing capacity, enough disease duration to get in, to look at who's going to get pulmonary hypertension, what can you predict as risks, who has borderline results, and how will those people be followed over time. And this has already generated probably about 6 or 8 publications, high data that are important to us as rheumatologists and the pulmonologists and cardiologists. So this is one of many studies showing that. And at this point in time, the people that didn't have pulmonary hypertension all were subjected with consent to right heart catheterization and then followed over time. So this is over 200 patients that were at risk that had a normal right heart cath or not too abnormal at the beginning and followed over time. But we're an enriched population, so I couldn't enroll every patient in this. They had to be longer disease duration and a low diffusing capacity to get in. Here's something else we've learned from registries. So it's really nice to show that survival is improving. And although it's kind of difficult to detect there, I tried to bold or change the color for some of the US ones, but I don't think you can tell in there in the North American ones. But basically, survival for both limited and diffuse has gone up every decade on the registries. And I'll tell you why maybe. So this is the survival. Then you can see here, looking at survival, 60 to 67% here of 10-year survival. Looking in the later 90s, you're getting 70 and 80% survival. This is a Quebec study, and their survival's in the 80% kind of range. And if I just say recent survival, you can see the survival here, 92% in our cohort of every person with scleroderma that we've seen in our site over since 1993. We had 92% survival of 10 years for the limited subset and 65% survival in the diffuse. So it's not that my site's better than another site, it's that what depends on the decade you start looking at patients. So I wasn't in practice in the 70s, so the survival has improved over time, which might be treatment, but it might be the natural history of the disease, that the disease has changed. We have better nutrition for people. We detect earlier patients. We detect milder limited. So in the Pittsburgh cohort, that was really the first large registry of scleroderma that started in early 70s. They had 60% diffuse, 40% limited. Then it was 50-50. Now it's the other way around. More limited, 60%, less diffuse, 40%. Diffuse has more complications, less survival, so survival can change just by the case mix. But we also look to say, you know, maybe there's a trend. So rheumatoid arthritis is definitely better now than 20, 30 years ago. For instance, people used to have vasculitis with their rheumatoid arthritis. They'd melt their eyeballs, so corneal melts, and they'd have more neck involvement. So everyone was to get a neck x-ray if you had rheumatoid arthritis before elective surgery, even before urgent surgery, because they wanted to make sure they weren't going to wreck their neck if they had rheumatoid damage there. And rheumatoid neck has gone down by it's gone down by a half and then another half, so it's gone down by a quarter over the last 30 years. Looking at registries, we've published on that. So we published on kidney crisis, scleroderma renal crisis, and we thought, oh, that must be going down because we have more limiteds than diffuse, less people are as sick as they used to be, less people are underweight and malnourished compared to before. And interestingly, we found that there wasn't too much of a time trend for renal crisis, but it's only in the diffuse in general that get renal crisis. So overall, it's going down because you got more limited that really hardly ever get it. So it was going down because of case mix, maybe not because of us doing better or identifying people earlier or whatever. So survival's improved, and this is just a Canadian 10-year survival looking at up to 1990, 10-year survival up to 99, and up to 2007, which is now a decade old, so I'll have to get a student to do it again, right? Just look at it again and see if we can do even better. But it is improving, and I think that's an important thing that the cohorts have shown us. You couldn't do a randomized controlled trial and show long differences in mortality because you'd never follow someone for 10 years. They did just publish that the survival of interstitial lung disease, the Scleroderma lung study 1 of cyclophosphamide versus placebo, that cyclophosphamide did not prolong 10-year survival, 5 to 10-year survival, but it was only 1 year of cyclophosphamide. After treatment, people regressed. It was the follow-up of that study that has given more information. So some lessons learned. We've learned about ulcers, we've learned about pulmonary hypertension, we've learned about site best practices from the Canadian Scleroderma thing. We did an early look at whether or not inflammatory markers were elevated, so C-reactive protein. So this was a study that helped, one of many things that helped to lead to a large randomized controlled trial of something that lowers C-reactive protein, Actemra or tocilizumab, an IL-6 inhibitor, because we found that about in early diffuse scleroderma, 1 in 4 or 1 in 3 had elevated inflammatory markers. And elevated inflammatory markers were predictive of lung disease worsening, were predictive of skin worsening, and lowering inflammatory markers was more predictive of skin improving over the next 1 to 2 years. So we found that from that study. So one of many things that helped to think maybe it makes sense to do a randomized trial. What we didn't learn, though, is we thought that if you prescribe immune-modulating, immune-suppressive drugs, so that's azathioprine, methotrexate, mycophenolate mofetil, also called Cellcept, and cyclophosphamide, that you'd actually get better results on skin. So the European database said if you prescribe this kind of stuff, matching for age, gender, disease duration, and skin score, that if you prescribe stuff like that, skin score improves over 1 to 2 years. We actually found that the skin scores didn't really change very much. So confounding by indication, maybe only the worst get this. Maybe we didn't do enough visits, but we looked at baseline and early diffuse, 1 year, 2 years, 3 years, and still didn't find any difference. But it could be all confounded. Maybe I don't treat the one with the same skin score that just, to me, looks less sick. So one thing we found from registries as well as trial data is that at the same stuff. In early diffuse, you got the same skin score, same disease duration. If you have better function, you will improve your skin more, probably meaning you're not as cased in it. So you could have a skin score that's 3, but you can still move a bit. Or maybe it's optimism and they know something we don't know. I don't know. Who knows? But anyway, from registries, it's something we didn't find, but another registry has found it. So you won't always find that, registries are the best thing since sliced bread. And this is just showing the outcomes of, with treatment, showing, okay, treatment in this European large registry of more than 15,000 patients has shown some good stuff happening with immune modulation. Now we also only report things that are good, right? You hardly ever report the null results. So we looked at finger ulcers in our patients. So 15% have a finger ulcer, not a tip ulcer, but a finger ulcer on any day coming into clinic. If you have one, you usually have more. So the mean number of ulcers, if you have one, is 2 point something. So because some are very multiple. And we found associations in limited and diffuse, some of these associations. And one association we found was that lung antibody, SCL70 or topoisomerase 1, also called topo1, was associated with bad ulcers. Well, maybe fibrosis or something. So we thought that's really weird. We were the first to report it. So then other registries found the same thing. So the French registry found it and the German registry found it. So it's true, but I don't understand it because we think of that antibody as being important for interstitial lung disease or fibrosis, but that antibody is also now associated from registries with bad swallowing tube issues, so esophageal dysfunction. So there's probably something to fibrosis with that antibody. Hard to say. And the U.S. registries, so there's the Scleroderma Clinical Trials Consortium, or SCTC. So it's more than, I actually tried to look this morning at how many sites, so I'll just guess. So it's about 80 sites, which means there's about double the membership because it's a site, and you can have up to 2 members at any site, and a lot of sites have 2 members. And it's mostly U.S.-based, some Canadian sites and some European sites. And for instance, as part of the Scleroderma Clinical Trials Consortium, the Canadian Scleroderma Research Group, and many members of the Scleroderma Consortium in the U.S./other places did part of the GWAS, the genome-wide scan from Houston. So Dr. Mays and colleagues. So we were able to contribute the blood and sometimes the saliva as well of our patients to do that. There's single-site data collections here that are really important in the U.S. So Pittsburgh has been a long-running database. New York Hospital for Special Surgery, they do a lot of single-site trials and have a database to find their patients. Hopkins, Ann Arbor, UCLA, Boston, it goes on and on. There's lots and lots of registries. Then there's Oregon registries like Pharos doing pulmonary arterial hypertension. And part of that, we did the DETECT registry, looking at patients at risk for pulmonary hypertension, getting then a diagnosis, and then moving from diagnosis onward. So the DETECT was who will get pulmonary hypertension, what's the rate over the next few years with at least 5 years disease duration and a low diffusing capacity of 60% predicted. So we weren't finding the rapidly progressive patients because they wouldn't have been included in the registry. So if you got early diffuse and you have pulmonary hypertension in a year, you wouldn't be in this registry. So you're going to find longer standing patients as being the risk. And the Pharos registry, same idea. You got to enroll people at risk for pulmonary hypertension because the ethics of cathing everyone, even sort of talking a payer as well as a patient into a right heart cath, there's problems. There's payment problems, ethical problems. So they, again, picked an enriched population. There's lung registries. So there's lung transplant registries comparing Hopkins and Pittsburgh, and I think another sites joined them. So we can learn from people that get lung transplants, heart-lung transplants in scleroderma, looking at the registries. This is one looking for early pulmonary hypertension. So 1,200 patients in the REVEAL registry, and 1/3 of the patients had connective tissue disease. The majority of those are scleroderma. So that's a big chunk of people. And they found that, I won't say predictors, the associations, because it was cross-sectional study. So the associations were a low diffusing capacity, longer standing disease, high brain natriuretic peptide level, things like that. So they could kind of look at some of that stuff. The European registry is giant, and they collect far less data than we collect in our Canadian registry, but because it's so huge, they can answer other questions that the Canadian one can't, whereas we can, for instance, look at cost utilization, healthcare utilization, beyond what the protocol makes you do, because if you're doing it anyway, because the protocol says you can't look at that, but we can look at hospital visits over the last year because we collect the data, allied health professional utilization, natural herbals, all sorts of stuff, whereas the European is 2 pages long. Our thing is about 25 pages long. So it just depends on what you want to collect and what you want to gain from it. The Scleroderma Clinical Trials Consortium, that's their website there, and they also post trials, but we have working groups for calcinosis, for vasculopathy, for pulmonary hypertension, for gut, for muscle, for renal crisis. So there's different working groups that you compare and combine data. So registries that are kind of virtual, you dump data together when it sort of pleases the investigators to find an answer, and then you get your IRB that way to do it. So how can I help? So for the farmer in the room, partnering. For the patients in the room, you can volunteer. I gave my buccal mucosa as a control for one of the GWAS studies, and I don't know what the control was. And I'll tell you, to take that and swab was really easy, but we had to do a spit test as well. I don't have a dry mouth. I have like normal. I thought it was normal. It took me a long time to do that, and that wee little thing gave me a huge appreciation of what I'm making the patients do all the time. You know, give me your belly, I'll do a skin biopsy, we'll do 2 on your arms, we'll do 1 on your belly. This is going this way. We'll have you do the same questionnaire twice. One's for standard of care and one's for the research study. You know, they get, the patients don't seem to get sick of it, but they could. It's a lot every time you do it. And you don't really fully understand how protected are my data, but they are all pretty darn protected. Although I guess if people can break into banks, and they broke into a bunch of health card numbers in the National Health Service a few weeks ago, they can break into some of our firewalls, but they're anonymized data for the most part, so your name is never up there, which is good. So how can anyone help? I think they can ask their specialist, hey, anything going on? So I have probably 1 in 20 patients will say, any projects? And I'm always shocked. It's like, haven't I worn you out yet? But so some people do ask and are interested. Some people say, how do I donate tissue? Because I'm going off for a lung biopsy. I want to donate the rest. Or when I pass on, how do I donate my organs for research? So they ask all sorts of things. But you can ask, are there registries, trials, data collections at the current site you're in? But also the Scleroderma Foundation will sometimes say, oh, we're recruiting for this study, or there's registries around. And for instance, I've had people, I don't know how they get my name when I think they just find my name. But anyway, I've had people say, you know, I'm in the US, I'm in tri-state area. What data can I find? What can I help to, help people, because I'm afraid of things. I'm afraid my daughter's going to get scleroderma because she has some early features and I have it for instance. And I know who to hook them up with because I know who's in the tri-state and where to go. But people ask and are looking for answers, and sometimes it's not their own expert that's seeing them. It's, one county over, and you can sometimes say, can I just go there once a year and you'll do the rest of my care, but I want to, donate to science. So if there's a will, there's a way. I certainly see some of my colleagues, patients, sometimes they just want to transfer their care to me, but sometimes they say, I'd like to manage this patient instead of having them drive 4 hours each way to see you, but will you see them minimally once a year and when they're in trouble? And can I use you for backup? Both, can the patient use you for backup, and can the rheumatologist use you for backup? And I go, sure, it's whatever works. And we're in a nice healthcare environment that we all can bill for that if it is standard of care, not if it's just research, but if I'm doing care for them too. So we're lucky that way. So there are often experts that will hook up the patients with other expert sites in their area. So I think databases have told us about the epidemiology of scleroderma, so the incidence and the prevalence and the mortality. They've shown us the epidemiology of organ systems, 15% with bad ILD, 15% with pulmonary hypertension, 15% with secondary Sjogren's, 15% with myopathy or myositis, 15% with inflammatory arthritis, etc. So that's what databases have shown us. How common are things? Databases have shown us sometimes if treatment works, sometimes safety of of treatment. Databases have shown us that screening for pulmonary hypertension leads to detecting people earlier, and it's not just lead time bias. There's actually a survival benefit if you follow those patients long term. I think research is finally catching up and that we need clinical trials, randomized trials, but we need registries, and to observe people in a rare disease, I think is highly meaningful to understand the burden of disease, of what people go through, but really to understand where should money be put. How common is this, and how much does it bother patients? Patients always say, if you could fix my calcinosis, my Raynaud's, and my gut, I'd be really happy. And I'd say, but it's your lungs and heart and pulmonary arteries that kill you. And they go, yeah, but I'd be really happy because day to day, that's what bothers me. So I think you have to look at research, a yin-yang of what's important to people, the burden of disease, how common is it, but how treatable is it? So I still can't treat calcinosis. I'll still study it and I'll still try, but I don't know how to treat it yet, but it is bothersome to patients. And we have biases and we don't always show the same results, and that's why I tried to give you an illustration of immune suppression not lowering skin score in one in the Canadian group, but lowering skin score in another group, and there has to be confounding in there that we haven't figured out. So let's have questions if you have any. And these are the trainees that do the work, and the funders are all in there too. So there you go. Yes?
Question about, so with the change in global movement, so you've got population in India, there's a large migration of these Indians to Canada. I don't know if you guys are following the distribution of scleroderma in that population. It doesn't vary in Canada versus what you might see in a registry in India for the same.
Right. So when people are moving from India to North America, say, there's a genetic drift because they start marrying off their kids into other cultures, or in general, not always. And there's an environmental drift, so they eat differently, often second generation, as a, for instance, second generation Japanese women, nothing to do with scleroderma, have breast cancer the same as San Francisco population, but first generation and in Japan have it about 10 times less commonly. So there's something about not just genes, their genes stay the same, although they turn on and off and different things, but there's something about the environment that drifts and changes your risk. So I can give an example I'm more familiar with, and then we can kind of try to generalize it. So Native Canadians and Native Americans have more organ involvement and more systemic sclerosis, but not all Native peoples, because not all Native peoples are, the Innu are very different genetically than around here is Apache and different populations, Puma. So they're not the same, but many of the Native peoples in this area, and really looking at a lot of the West in U.S., have more scleroderma, more interstitial lung disease, so more organ involvement for interstitial lung disease, and a different antibody profile. And people have even compared for China, Chinese Americans, so Maureen Mays has done some of that work comparing to China and Taiwan and looking at the antibodies. So some of the antibodies that we don't even measure that much, THO to TH1, we can't do that in a commercial lab, are different. And the rate of organ involvement for the Chinese and China for lung disease is less, which is interesting. In African Americans in the US, they do worse. They have more healthcare utilization. They are in general rural and poor, and they do worse. Our Black Canadians are usually urban, educated, and don't do worse than the Caucasians. So there's an example. When you look at, for East, looking at India and migrating here, I can tell you a lot about lupus because we know about lupus, and I'm in a lupus cohort, of course, as well. I have my finger in many pies. But for lupus, the Pacific Rim Asians have far more lupus nephritis than in India, but they get less damage than the Canadians that are Caucasian or Black, and the Native peoples do the worst in kidney nephritis, so lupus nephritis. So the changing populations, people will start looking more like where they live, but there are definitely differences. So in lupus, we know higher chance of kidney lupus, but less damage. which is interesting. So they have activity genes and less damage genes. For scleroderma, pulmonary arterial hypertension is not the same, like we looked at all those cohorts to say it's about 15%, but the rates will vary. And again, sometimes the antibodies will vary. So in India, I don't know, if you move to North America, you're probably, possibly, not always, possibly more affluent. And we know the nature nurture. If you have bucks, you in general do better in any healthcare situation. And not always, but in general, and not much better, just a bit better. So, and it might be the resources, it might be the knowledge to have better healthcare related behaviors. If you're really poor, maybe you don't have the best nutrition because you can't afford it. So not just smoking, and drinking doesn't know a class effect. We studied that in many diseases. So alcohol use, the same amount of high frequent drinkers or low frequency drinkers, or doesn't matter socioeconomic status, interestingly, but smoking definitely. The more educated you are, the less you are apt to smoke. So the prevalence of smoking and the population in rheumatoid arthritis and lupus and scleroderma changes by socioeconomic status. So there's a lot that factors in. So a short question with a very long answer. So the real answer is, I don't know, but probably changes. Right, so some people in groups, I'll repeat the question. So is there a group in Canada, US, elsewhere looking at genetics and different populations, so those who have migrated in and stuff? So there are certainly groups that look at, it's really hot right now, so the changing of DNA, so the methylation of DNA. So if you change DNA in, your DNA is the same in these identical, as for instance, mice. And if you methylate some and not others, you can have the mouse with a brown coat and a white coat and something in between and a mosaic one. So we know that even on identical twins or triplets or whatever, that environment, whether it's in utero or post-environment, dietary environment of mom and stuff, has all this effect. And that's really hard to weed out. But people have been looking at funny things, it's not that funny, but pollution and factories and autoimmune disease. So that's very broad. Now we're not talking scleroderma, autoimmune disease. And then they also look at migration. So if you're rural and everybody's kind of white bread, so to speak, they're all kind of homogeneous in that area. They might have all come from somewhere eventually before, but maybe they all emigrated from somewhere. Like the lost Dutchman up in the mountains is actually a German, just saying. So he's not even a Dutchman. So people also forget where they're from sometimes over time. But basically, homogeneous groups are easier to study than heterogeneous. And so that's been looked at. But the GWAS scans, the genome-wide scans that we were involved in scleroderma, lupus, rheumatoid arthritis, only allowed Caucasian of European ancestry. So right there, in large studies, there are genome-wide scans in other countries that obviously have different characteristics, but great big U.S., probably funded in part by NIH, and it did that because they said we got to look at some of the major, these are polygenic diseases, some of the major genes, and then start looking in other populations and say how frequent is STAT4 or PD, whatever, all these various genes that do things turning on and off autoimmune cells like B cell regulation. So I think we'll know more of it, but on the other hand, most genome-wide studies have not gotten us a lot further in the clinic. In understanding, yes, but in the clinic, no. So an exception might be belimumab, a B-cell signaling changing drug. It inhibits the cell talk. Belimumab was developed because of a genome-wide scan in lupus and saying, wow, this BAFF, APRIL, kind of these B-cell signaling things are really upregulated. Maybe we can find a drug to lower that regulation, to turn it off. So there's one example, but there aren't many because they're so polygenic. And you go, well, we can't really downregulate that thing anyway. Or we downregulate with a, not a bullet, with a bomb. Okay, I'll just turn off, I won't turn it off, I'll just turn down the cytokine and let's see what happens. So I know what I'm doing, but there's a lot of it's soup. So I just change one ingredient, but it still tastes salty in the end. It's a bunch of soup. So it's tough. But these are, registries will help us. And the cool thing is a lot of registries freeze serum, not all freeze skin biopsies and stuff. But it means that if there was a discovery, we could go backwards and say, holy smokes, 30% of our patients this might be relevant to, but not all of them. So we're not there yet, but that'll come, I hope. In my lifetime, I think it'll come.
So thank you so much for all that great information. I hope someday it gets updated to 2018.
Yes, that's right. That's why we have
by
students.
an intern in the world, right?
Yes.
So sitting here are two executive directors of two different foundation chapters in this country. What can we do to support input into information in the U.S.?
Right, so I think to support information for your local chapters are a couple things, because you can't really update what's going on as regularly as you would like. You know, a lot of you are running on volunteers and things change all the time. But I think links to other things like the Scleroderma Clinical Trials Consortium. I found something talking about the relaxin trial, which was like 99 or 2000 and something. It wasn't 99, but it was 2007 or something, was actually on the website. But I think it was somebody's PowerPoint thing saying this is recruiting. And I thought that's so embarrassing to be up there. But the working groups were there. The member sites have to be there somewhere, because I was trying to find all the member institutions. And then when somebody says, hey, I want more information, often your chapters are information giving because you link to the Scleroderma Foundation. You've got excellent pamphlets on many different things, which I think are written at a level that people can understand. But if people want to get involved in research or have their family involved, and sometimes they're even controls. They say, my best friend has scleroderma, can I be a control in something? I think to say, well, the Scleroderma Clinical Trials Consortium, and for each of your chapters, you'd probably say, and our big sites, because Tri-State, for instance, doesn't have a lot of scleroderma sites for Tri-State, but yet they raised enough for a whole extra grant for Scleroderma Foundation. But I've given lots of talks for Tri-State because I'm right beside one of the one of the states. I'm actually beside a couple of the states. But they basically, it also helps to generate interest. So when I go give a talk next in, say, Albany, they'll want me to go knock on some doors as people in Albany of interest with scleroderma start retiring. Hey guys, who can be interested? Where'd you train? Didn't you train with one of my trainees, et cetera, to get sort of that going. So I think to facilitate on the major cities in your area as well, a scleroderma interested site. Because if you have an interest, the patients do better. So, and that's true for, somebody doing, fancy robotic surgery. If you do enough, a critical mass, you're better. And it's not just because the doctors learn, it's because the allied care that goes around it. I work with expert GI guys now, and why are they expert in scleroderma? Because I've referred them hundreds and hundreds of patients over the last 20 years, right? So they, by default, one guy became a dysmotility expert because he got all my patients. Said, jeepers, I guess I should learn about this. So expertise clusters.
And to add to that, I sit in Philadelphia, right? So University of Pennsylvania has a scleroderma center at the Perelman Center, and is there anything I can do to encourage the physicians and team there to participate, like Pittsburgh does, which is 8 hours away from me? So.
Exactly, and in Pittsburgh's right. It's a long drive, and you don't know if their health care will pay for them to go when they've already seen a specialist or subspecialist, as the case may be, in their own area, things like that. So I think, again, possibly saying, we'd love a little awareness day. It can be a lunchtime. It doesn't have to be a day. And leaving talking to people that might be interested. So often you start, if you don't know, the division head, okay? There's every rheumatology group that has a teaching program has a division head. So not the program director, they're busy doing other things, but the division head, and saying, don't you think you owe it to patients with a rare disease that really falls under rheumatology to develop an interest, and how can you work together with them? Because it's often not money, it's awareness. It's sometimes someone to go spend a month or two with another group to say, oh, we know how to do that protocol now. That's just collecting serum and storing it properly. There's, within and between institutions, the contracts are horrible, but for observational registries, it's not as difficult as it could be, because you say a lot is standard of care. You could say, well, if it goes on your EMR, would that facilitate? Could a small grant to get the data, like the skin score, get on the EMR, and that will help. That if it's there, it'll get collected. If it's not there, it won't. And then I think facilitating IRB. So IRBs in Australia, as an example. In Australia, Everybody is an opt-in to research unless if they opt out for certain registries. So you're in unless if you say you're not, and it's posted in the waiting room, it's posted in their exam rooms. These are easy data. They're not taking serum and freezing it. That you have to get a different consent for, but they have a registry, OPAL, that is a bunch of Australian rheumatologists, and every patient with every diagnostic codes in unless if they opt out. And the opt-out rate is about 0.5% because first of all, people don't read it. And secondly, they go, well, if everyone else is doing it, I should do it. But then they can actually say, so they started with rheumatoid arthritis, psoriatic arthritis, so they're moving into connective tissue disease now. So if they put on some of the standardized forms, people will use it in the EMR because it's a dumping of their electronic medical record. If it's not there, they're not going to do it. As soon as it's something extra that's difficult, it's harder. So I think saying, you know, how can you facilitate by money or a programmer or something to do that is a lot easier because you can do a minimum data set and learn a lot. You answer different questions when we're collecting 1,000 chunks of data on people potentially annually. It's different stuff we'll learn, but there's common ground of age, disease duration, subtype, antibodies, and stuff like that. And antibodies don't have to be centrally done. So I think those things allow, and then again, once the trainees get published, get interested, that generates the next generation. Because people become what they become as subspecialists because of mentoring. They see someone doing it and they go, hey, I'd kind of like to do that. Or there's a real opportunity to learn in this area. So I haven't said many bucks, and you don't need many bucks to do those things. Yeah?
Thank you.
Good. You're welcome. Good. Okay, we'll cut it.